Hello, my name is Tina Collins, and I'm the Corporate Director of Medication Safety for Christus Health. Welcome to Innovation in Safety Event Detection. What's really happening in medication management? Today, Leanne and I are going to share our experiences in utilizing tools from VigiLanz to innovate our med safety program. Safety event reporting is an important component of establishing and maintaining a positive safety culture. It's a process designed to improve safety within health systems by providing insight into root causes of harm. This is a voluntary process that requires awareness of the event as well as really a willingness to report the event. Without these insights from safety reports, threats to safety could go unresolved and cause significant damage to a patient's physical, mental, and financial health. By increasing the reporting frequency of safety events and near misses in health systems, we can gain a greater understanding of safety challenges and prevent future harms. However, it's common for healthcare organizations to experience underreporting of safety incidents. This chart really highlights the perception of reported safety events. Perception versus reality. You know, it's funny, sometimes people say people's perception is their reality. However, I would beg to differ in this case. There is an overall belief that reporting is occurring often. However, a study released by the U.S. Department of Health and Human Services, roughly 86% of patient safety incidents occurring go unreported. So how do we ensure that more safety events are reported? Let's talk a little bit about the barriers to event reporting. Sometimes event reporting systems or forms may be too long and people may perceive that it takes too much time. People are busy, and lately healthcare we're really short-staffed, and so they're just trying to get through their day and they may forget to report. Or likely, I don't know about you, but in the pharmacy world, we're really bad at just fixing things and moving on, what I like to call a fix and forget mentality. Sometimes incidents may seem too trivial to report, or we're not even sure who's supposed to report it. Or even we may be hesitant to report for fear of negative repercussions. What does your safety culture look like at your hospital? So let's talk a little bit about auto detection and how it can help overcome many of these barriers, and really how we have tapped into that at Christus Health. So what is auto detection anyway? It's using technology to scrub your electronic health records for specific identified rules that run in the background. These populate into the safety event reporting system as Autogenerated Potential ADEs, or Autogenerated Safety Events. A clinician is assigned within the system to investigate these, just like any other voluntarily reported safety event. Really, before I go any further, I think it would be prudent to provide you with some background definitions on terms that I'm going to be throwing around today and making sure that we're on the same page, because there is significant confusion regarding these terms. I like this diagram because it shows you the relationship between medication errors and adverse drug events and really harm. An adverse drug event, or an ADE, has been defined as harm associated with any dose of a drug, whether the dose is normally used in man or not. An ADR is a subtype of an ADE. So all ADRs are ADEs, but not really vice versa. By definition, all adverse drug events, or ADEs, are associated with patient harm, but not all of them are caused by an error or are preventable. So why am I telling you all this? Standardized use of this terminology will help focus your attention and efforts at eliminating preventable harm, but first you have to be able to define it. Adverse drug events, or ADEs, like I said, are injuries resulting from medical interventions related to a drug. It's important to know there's not a causal relationship necessary if you have an adverse drug event, but there is a temporal relationship between the use of a drug and an event. Adverse drug reactions, on the other hand, really refer to any unwanted reaction to a medication that occurs at normal doses during the proper use of the product. It's an adverse drug event that does have evidence to suggest a causal or suspected link with the drug. The event is unintended and there is harm. It is really a subcategory of an adverse drug event. Some examples of adverse drug reactions include an extension of the med's pharmacologic effect, an allergic response to a medication when the patient had no previously identified allergies, an asthma exacerbation with a beta blocker, and rhabdomyolysis with a statin. Medication errors, on the other hand, are defined as preventable, inappropriate use of a drug, or an error in the medication use process that may or may not result in patient harm. Healthcare professionals or patients can make medication errors. Medication errors can occur in the prescribing, dispensing, distribution, administration, or the way the patient uses the medication. Let's talk a little bit more about the rules being used at Christus Health. These are the auto detection that we are currently taking advantage of. You've likely heard of IHI trigger tools, but have you really seen them in action? A trigger tool that's coupled with technology so that you could generate a safety event to be investigated, a lot of times in real time. We have the unique opportunity to partner with VigiLanz as we standardize all aspects of safety event reporting. This is the data from after the go live and utilizing auto-generated safety events. We were able to capture an average of 19 additional events per month per facility. So when we do get those auto-generated potential ADEs, here are what we do next as investigators. We have to sort through them and figure out, how do we classify them next? Well, number one, it can be considered as non-preventable, and then it would be classified as an adverse drug reaction, kind of like we just talked about a few minutes ago. Number two, it can be considered as a preventable event, and then it would be reclassified within the safety system as a medication error. Or lastly, and this does happen, but not to a huge degree, it could be considered not a reportable event or noise. That is why it is so important that not only do we have this great technology that we can use, but we have an engaged person at the other end of it, making heads or tails of the information. This is a little bit more of the auto-detected events we were able to capture since the go live. And you'll see that we only had about 15% that were closed as not reportable, which tells you it's not a lot of noise. So it's highly usable information, and it's highly customizable as well. And then you'll notice this is our data from simply manually reported adverse drug reactions. Once we were able to utilize auto-detected adverse drug reactions, we had a 400% increase over manual reporting, and that's huge. So I'd like to kind of recap the benefits that we've been able to appreciate, and those are improving efficiency, accuracy, and completeness of events reported. Not only have we gotten more reports, but we've gotten a higher quality of reports. These events occur in near real time. It allows patient safety and claims managers to quickly intervene when or if necessary. And it bypasses resistance to reporting, or even if there is a knowledge base that you should report, because it feeds directly from information available within our EHR. And it gives a more comprehensive capture of what's really going on in the organization. Now I'd like to pass to my partner, Leanne, and let her tell you a little bit more about what she has experienced at St. Francis Cabrini. Go ahead, Leanne.
Thank you, Tina, for that great introduction and overview of this innovative process. As Tina mentioned, my name is Leanne Malone. I'm the clinical manager of St. Francis Cabrini Hospital in Alexandria, Louisiana. I'll be talking about some of our wins since implementing this VigiLanz safety tool. Perhaps one of the most obvious wins for our facility was the dramatic increase in the number of validated ADRs that were reported during the first month of implementation. This level of reporting has remained fairly consistent in the 2 years we've been working with VigiLanz Safety, and it continues to provide vital information relative to patient safety. So what does the reporting process look like? How do auto-generated events translate to usable data? As we all know, the generation of events isn't enough to have a successful program. If I present 20 auto-generated adverse drug events to our pharmacy and medicine committees, it's not meaningful data. Providers and leadership want to know what we've learned and how we aim to prevent them from occurring again, or if we even can. We must hardwire that process for determining if an ADE is a true ADR versus a med error or an unreportable event. At our facility, this process is owned by a trained pharmacist. If an event is determined to have been preventable, it's reclassified and automatically routes to the designated leaders for review. It's very important to set expectations for this process and involve senior leadership. For my site, if any case is greater than 7 days old and has not been reviewed by designated leaders, a report is generated and communicated to risk management as well as our CNO. This process has guaranteed successful event analysis, as well as ensured rapid feedback to specific leaders and process correction. After event analysis has been completed and all events have been appropriately categorized, we can now utilize the integrated reporting system to look at our data. So looking back at the first graph I presented, I've removed the medication error data so we can focus specifically on ADRs. You can see what a significant impact the auto detection system had in the very first month. Prior to VigiLanz, ADE reporting at our facility was so minimal that it was almost impossible to spot a trend versus an anomaly. For example, in 2021, our first full year of VigiLanz safety reporting, associates reported 3 ADRs related to anti-diabetic agents, while the VigiLanz system auto generation tool captured 120. With this volume of auto-generated events based on relatively common adverse reactions, allows your investigative team to spot and target trends much easier, increasing the frequency of otherwise unreported events. With more data, especially reported in standard formats, integrated reporting tools can easily be utilized to filter common events down to unit-specific trends, allowing for targeted and meaningful education. Further evaluation of our 2021 data shows that auto-generated events accounted for almost half of our total reported events, confirming the data that Tina presented earlier, that approximately 50% of all medication-related errors are not voluntarily reported. Of the 303 auto-generated events, 18 were determined to be preventable medication errors. Of those 18, 9 were associated with patient harm. Overall, auto-generated events have been responsible for identifying 28% of all medication-related harm since our go-live in October of 2020. These are events that would have otherwise gone unnoticed. So now that we know they're happening and we have the documentation trends, how do we facilitate the change? At Cabrini, we've been able to implement a number of performance improvement and process changes to improve the safety of our patients and staff using this standard flow. It's very similar to an SBAR. So, event validation. Is it a preventable error? Investigate your root cause. What went wrong? Identify your key stakeholders. Who owns the process? Interdisciplinary problem solving. We don't live in silos. How does this process impact pharmacy, nursing, providers? And then target your education. Make it specific to the root cause of the error. So looking at that process on a specific activation, we look at D50 administration relative to insulin. So we have several auto-generated events related to insulin therapy, whether it's long-acting, intermediate, or short-acting. This one specifically alerted to an administration of a long-acting insulin within 12 hours of a D50 administration. This activation prompted investigation into the patient-specific therapy. While investigating, we noted discrepancies in dosing of the long-acting insulin relative to order parameters. Seeing this, we then broadened the scope of the investigation and audited several charts. And we noted an increase in non-administrations without provider order or notification. So then we identified the stakeholders. Who can help me figure out why this is happening and who is in charge of making changes to the process? Once we identified nursing, education, and pharmacy leadership, we developed facility-wide education for nursing staff on insulin therapy. We created a stepwise approach to ensure understanding of the types of insulin and duration of action, schedules, and non-administration procedures. And with that, I will turn it back over to Tina Collins.
We'd like to thank you for coming to this presentation today on behalf of Christus Health and our partners at VigiLanz.